Okay, and good afternoon, good evening, and maybe good morning. So I see that there are some attendees from Europe still registered for this webinar. And okay, let's allow the recording. And so good morning, good evening, good afternoon, everyone. My name is Peng Sun from Post Medical. And firstly, welcome everyone to join today's webinar. And so today's webinar's name is Precise PCI, Integration of Computational Physiology and Intravascular Imaging. And today we're extremely happy to have Professor Gong Ku Ko and Professor Shengxian Tu and Dr. Lei Song and Dr. Junqing Yang together and share their professional experience, comments, and regarding to the computational physiology and intravascular imaging. And today we're also very glad to have more than 150 people from different regions to register and attend this webinar. So at the beginning, let's welcome Professor Tu to give us an opening speech. Professor Tu, please.
Thank you, Peng Chen. Good evening, everyone. Thank you for taking your evening time to participate in this webinar. As you might notice that the AI has revolutionized every corner of our life. So over the past few years, we have witnessed significant progress in the field of computational physiology and black vulnerability. So today we are here in this webinar to discuss some fundamental about the technology and as well as their clinical application. I hope that you will enjoy the evening, and as Professor William Vai mentioned in the close ceremony of the EuroPCR, the wind of AI is coming. So I hope that we can all together to make the wind stronger. And thank you again for your participation.
Okay, thank you, Professor Tu. And so at the beginning of the first topic, let's welcome Professor Bong Kwong Ku from Seoul National University Hospital to give us a speech with the name of Practical Application of Coronary Physiological Assessment. So let's welcome Professor Ku.
Okay, so can you see my slide?
Yeah.
Okay, good. So that thanks for the invitation for this great session, even for the quite late evening here and there. So today I'm going to talk about the practical application of coronary physiology assessment. I am going to divide my presentation into two parts. The first will be about the classical invasive physiology, and the second part will be image-based physiology things, which is quite new kids in this block. Last year, with the help of almost all key opinion leaders in Asia Pacific regions, especially with the Dr. Tu's team in Shanghai Zhejiang University, we developed and published the Asia Pacific Expert Consensus documents, which is quite long. And my duty today is to summarize these long expert consensus documents so that as you can imagine, it's not possible to summarize these two very long documents into 20 seconds so that I strongly recommend you to read these two expert consensus documents so that you can enjoy the taste of the Asian Pacific experts consensus documents. Having said that, first, I would like to talk about the invasive physiologic assessment, talking about 10 commandments, or starting with the rack-up issue. I think the most important element in applying the coronary physiology in daily practice in the cath lab is to select the right target. You may already know the results of REPORT 2 trial, which tested the benefit of routine or the all-comer physiologic assessment, and that systematic physiologic assessment was found to be not beneficial. So it's natural that we cannot apply any procedure to all patients. So first you have to do a very careful observation of the angiogram, and generally physiology is helpful in intermediate or ambiguous lesions. And your physiologic assessment, either invasive or non-invasive or imaging-based, clinically relevant vessels and lesions, and the lesions or vessels that deserves revascularization. And these are only for the invasive physiology. You cannot be very successful in heavily calcified or very tortuous lesion. So here is a typical physiology adequate lesion, intermediate lesion in mid-LAD and bifurcation lesion. And the other thing is that the jail side branch lesions involving ramus circumflex and first diagonal branches. So in this case, you'll get to know when you have a physiology, either invasive or non-invasive, both LAD and diagonal branches not significant. And for these ambiguous lesions, when you have a pressure wire, you can get to know that this is significant, insignificant, insignificant. But there are some tricky situations. Here in this quite tortuous vessels, but doesn't look like that significant, but FFR is 0.59. So you may consider do a very complex procedure for this case. But when you see an angiogram with the pressure wire in, you see there's a lots of accordion or the artificial stenosis made by the pressure wire. So I think these tortuous lesion or some calcified lesion can be a very right target for the non-invasive or image-based physiologic assessment, avoiding these weak points of the invasive physiological assessment. And also you have to very carefully assess the clinical information to avoid the unnecessary procedures, even for the physiological assessment, and also to make a right clinical decision making. And the third part is you have to know and assess the knowledge of yourself. So if you do an invasive procedure, or even you do image-based physiology in the cath lab, those are based on the invasive imaging. So it's basically an invasive procedure and carries some risk. And when you are working with the pressure wire, you have to understand that the quality of pressure wire, although it's now much improved since several decades ago, but we know that it's not exactly the same as the workhorse wires. And the benefit of procedures, either invasive or non-invasive assessment, depends on your knowledge and experience on coronary physiology and indices. So there can be a general application and advanced application of pressure wire, and it also can be applied to the image-based physiologic assessment. So in cases when you find some discordant numbers in comparison with the image findings, such as angio, IVUS, FFR, before you say that this is mismatch, angiographically significant, physiologically negative, or this is reverse mismatch, angiographically insignificant, but physiologically significant, you have to check all these potential possible limitation and weak points of the invasive physiological assessment before you say that this is mismatch and reverse mismatch in this very significant left main lesions. And you have to understand that the system and processes very well. When you are working with the invasive procedures, you have to understand the device connection, equalization, introductory effects, etc., drift and accordion spasm. And you also have to understand also the non-invasive hemodynamic assessment, the weakness and strength, and that is the key to make a right decision and after a right number. And when you do a invasive and non-invasive physiological assessment in the cath lab using any of these angiogram, you are not there to get the number, but you are there to have an adequate number to do a right clinical decision. So I strongly recommend that not just measuring physiology, MUFR, QFR, FFR, IFR, before you measure it, predict the number, and then you can compare your prediction and the number. If it matches very well, that measurement may be accurate in general. But if there's a discordance, there's something wrong. So you have to try to find the reasons why there's something wrong. So here are you looking at around 10 lesions Let's see whether you are accurate or not. So if you can predict all these numbers in these 10 lesions, you don't need to measure physiological assessment, simply do a visual estimation. So here, diffuse looking LAD lesion, FFR 0.76, looks significant, jailed circumflex 0.69, very significant, almost 90% jailed circumflex 9.3, this significant looking very large diagonal branches 8.9, significant jailing of the first diagonal branches and circumflex, IFR negative, FFR negative, IFR negative, FFR negative, and these lesions resting PDPA negative, FFR positive, resting PDPA negative, FFR negative, FFR positive. So this is the reason why I am measuring physiology using image or the invasive physiology, because I cannot predict this number accurately even after measuring FFR for over 20 years. And then I don't want to talk about in detail about the resting indices, but I'm not arguing which is better. But one thing you have to remind is that it's also same for the invasive and non-invasive physiological assessment and resting versus hyperemia. They're not exactly the same. They're telling their different messages from their information. So you have to understand basic differences. But the more important thing is not which is better, but more adoption of either invasive and non-invasive physiology-based approach, because you know that the now FFR, IFR, and image-based physiology are all regarded as a class 1A indication in recent revised European guideline for stable coronary disease assessment. And now, if you are using FFR, you don't need hyperemia. That's the beauty of the image-based physiology when you apply the MUFR, but when you're doing wire-based physiology, you have to wear the hyperemia. So without adequate hyperemia, all your measurement will mislead you, underestimating of the lesion. So you have to understand all these potential limitations, or when you are doubtful about the optimal hyperemia, you have to check all these elements before you say this is accurate or not. And while measuring FFR, this is a typical physiology, invasive physiology curve. FFR is 0.91. So after giving adenosine, you see that the pressure decreases and FFR gets lower. But when you have these images, you always have to check the PA signal of these images. So here, resting hyperemia started, you see that the PA gets a little bit damping. And during the maximum hyperemia, PA signal has been completely ventricularized. So in this case, when you pull the guiding catheter a little bit, you see that FFR 0.91 becomes 0.83. You see that the ventricularized pressure has been normalized. So this is one of the most frequent mistake that's done by the general that's done by the beginner. So you have to be very careful about that. But you don't need to worry about these kind of pressure damping issues when you're doing non-invasive or the image-based physiological assessment. And I cannot stress more about the importance of pullback. Previously, physiology was used only for the per vessel index PCI or not, but now we understand either using invasive or non-invasive physiology, we understand the importance of pullback. And here are two lesions. You can understand that this lesion should be the primary target of the lesion. And physiological lesion distribution is very important in terms of symptom improvement and also the patient outcome. So that I don't want to go into the very detail of this physiologic lesion distribution, applying the PPG, DFFR, DT, etc. But when you do a pullback, these are the cases when you have a maximal benefit, but these lesions cannot provide you a good benefit after revascularization. And finally, before I move into the non-invasive or image-based physiology sections, you have to understand that you are the responsible person for decisions. Do not let numbers overwhelm you. So here is a case after stenting approximately the FFR is 0.79. So if this is below the 0.8, so you are worried about the other lesions or the in-stent segment safety or efficacy, but when you do a pullback, you recognize that the pressure step up occurs only at this far distal lesion, which do not have a significant benefit after revascularization, and delta FFR across stent is only 0.03. So even 0.79, I will be happy with this rather low numbers. And having said that, let's think about the image-based physiology. So we are in the era of image-based physiology. I think we are already having more than enough. So it is very important to understand the basics and clinical applicability of image-based physiology, because I personally think this really is the future. If I have to invest and choose one, either invasive and image-based physiology, I have to invest most of my money to the image-based physiology. And that's the reason why we are here at this late evening to learn more about the computational physiology or image-based physiology. If I briefly mention about my history about interest in non-invasive physiology was that while measuring, so since 2003, I've been measuring physiology. So it's more than 20 years. So while measuring physiology for several thousand cases, suddenly I thought to myself that whether there's a possibility to get the hemodynamics from static images, which means that the measuring FFR without invasive procedure, pressure wire adenosine. Now it is so common, so everybody knows how to do it, but 15 years ago, it was simply a crazy idea. But I was interested in that. So these are very, very early model for the CTFFR and treatment planner model. So this is the first model that the FFR concept was applied in this human coronary circulation, which was 16 years ago. And then start with the CT-derived FFR, and you know this story very well. And this is the first slide presented 2011 about the concept of CT-derived FFR, which enables us to estimate or calculate FFR in any of human coronary circulation. And then this can also be applied to treatment planning. And later, I'm going to talk about these techniques using the UFR technique. So serial lesions, it's not surprising the physiology is significant, but practical question is how we can fix this lesion, because the lesion, the patient have, this LAD lesion have at least 1, 2, 3, 4 tandem lesion. So it's tricky, but using this computational technique, you can either, like playing a video game, you can pick this one, post-physiology, pick this one, post-physiology, and you get to know that after fixing these two lesions and leaving these two lesions, you relieve ischemia, and following that strategy, predicted FFR 0.86 and measured FFR CT FFR 0.9. And these treatment planning strategy now have been evolved to the surgery planning. So here's a case example, a case illustration, but this old lady underwent bypass surgery without invasive angiogram, and follow-up was also done by the CTFFR. So this is a real-world practice. And having said that, I'm happy to introduce some concept I learned from the Professor Tu's lab about the invasive imaging-based physiology. You know that the post-medical or the Shanghai Jiodong medical team or the Dr. Tu's team, whatever you name it, is a kind of pioneer in these issues about image-based physiology, even from the QFR systems. So basically, from coronary imaging, either angio, OCT, IVUS, they can generate the three-dimensional vessel geometry, and using computational mathematics or the physiologies, FFR can be estimated. And all these data are supporting that the accuracy is far better than IVUS, OCT, or any image alone assessment. And either QFR, OFR, UFR, MUFR is very close to the sensitivity and specificity high level to the FFR. So this is a table extracted from our consensus paper, and you see that among these commercially available systems, post-medical have a CT-QFR, UFR, OFR, and UFR. So whenever I'm meeting Dr. Tu and his team and post-medical, I'm always surprised at their progress in the field of image-based FFR and computational FFR, and they're progressing and generating a bunch of evidences. And the most popular system from the post-medical is actually NGO-derived FFR, but they also have a CT-derived FFR, which can be used as a gatekeeper to the cath lab. And the beauty of this system is it can be possible to perform an on-site application. You know that the heart flow FFR CT requires to send the images to their system so that you have to overcome the barrier of the electronic barrier of each hospital system. And what is more common to us is applying this UFR into our daily practice. So in this case, LAD, circumflex, RCA, very tight stenosis in proximal LAD, and some stenosis in circumflex, and mild diffuse disease in RCA. You see that the MUFR LAD definitely positive, MUFR circumflex positive, and MUFR RCA negative. So these two vessels will be the primary target of the treatment. And you can also do a virtual PCI planning using this system where you have three-dimensional vessel models, and you can plan that after virtual stenting of the proximal LAD, expected post-PCI MUFR is 0.96, and after fixing all these lesions in diffuse tandem lesions of circumflex, you can expect the residual MUFR is 0.97. So this is the PCI proximal LAD and two stenting in the circumflex. You see that this is a measured UFR after PCI. You can also assess the post-PCI assessment after remeasuring after stent implantation, LAD MUFR 0.93 and circumflex 0.94. The very interesting application of this technology in the real world practice is a tandem lesion. So when you use the invasive FFR, 0.67, very significant, but it cannot tell you how to fix these lesions, fixing the proximal lesion, either distal lesion alone or fixing those two lesions. So because there's a kind of crosstalk among these lesions. So, but this is computational technologies. So here in this MUFR, overall MUFR is 0.56, very close to 0.76. And here you can get the delta MUFR across the lesion 0.21 and distal lesion 0.17. And after fixing this lesion, residual MUFR is 0.79. So one stenting may not enough. And after putting one stent, you will have a residual ischemia in this patient. And this is the FFR measured after stent implantation. As you see in previous estimation, after fixing the proximal lesion, FFR post-PCI FFR is 0.79. And here, after fixing the second lesion, residual MUFR or predicted post-PCI FFR after fixing those lesions is 0.96. And after fixing those two lesions, you will get to know that invasive FFR is 0.90, very close to the predictive value, and measured MUFR after two stenting is very close to the value. So this is the value of this system when you apply the clinical complex system. And also this can be applied in the MI, non-corporate vessel, and you'll get to know more and more the value of this system in this non-corporate lesion in the emergent setting where the invasive physiological assessment can be cumbersome to perform in this situation. So you can also do a OCT-based FFR, or when you do a IBUS-based FFR or UFR can be helpful. And bifurcation lesion also, the beauty of single view Moray-Low-based angio-derived FFR is you can also do a side branch assessment using with the single view, and which can be very helpful to define the selected adequate treatment strategy for this complex bifurcation lesion. So this is my last slide. So we are living in the physiology field, but the way you apply in daily practice either invasive and non-invasive physiology is very important to your assessment and for the patient outcome. So you have to be rack up, resting, and be happy so that you understand these elements, then you will be happy and the patient will be happy. Thank you very much for your kind attention.
Thank you, Professor Ku. And I think it's very interesting topics, and very glad to share these valuable things, not only about the wire-based traditional physiology, and also you mentioned a lot of different image-based, and also we see that it's very increased fast, and also the very good one for the application of the in the real case workflow. And also let's see, is there any question from the chat box? So first we see their question about what's the benefits of the CT-FFR?
Yes, so as I mentioned earlier, the benefit of CT-FFR is it's complete non-invasive assessment. But we understand that the accuracy is not as good as invasive image-based physiological assessment. But when the performance is compared with the other non-invasive assessments, such as a SPECT exercise stress test, it's at least equal or the better performance, so that its accuracy is around 85 at best, but it's outperformed the other non-invasive tests. So it's completely non-invasive test, and that's the benefit of the CT-FFR.
Okay, thank you, Dr. Ku. And I see another question. Should we always use the physiology guidance during the PCI for all the vessels? And should I always treat the vessel with value lower than 0.80?
I think this is a very important question, so that recent PREVENT trial, IFFR, vulnerability, PCI is better than medical treatment. So I think the border has been already broken. So for low FFR lesions, you have to select the right lesion that can really beneficial after the physiological lesion distribution. And even for high FFR, for example, 0.82, 83, 84, if the lesion is very vulnerable, I think we can fix the lesion. So that's the beauty of this co-registration and UFR and OFR, because when you do a UFR and OFR, or the RWS, those integrating of image and physiology, and then you will have a superior information than 0.80 versus 0.89. So that will be the future. And that's the reason why we are here today, so that and I know that the Dr. Tu will provide us some more tools to make this done very easy way.
Okay, thank you. And another question, I think maybe all of the speakers can answer this question. So how can I select the wire-based or the image-based FFR? So maybe
So that's
Professor
also
Ku.
a very important question, so that I think that the overall angio-derived physiology can replace invasive FFR around 80 to 85%. But as I mentioned earlier, you have to very carefully observe the angio. And when your number is against your decision make, against your estimation, or it's really a borderline, 0.85 or 0.78, and you want to assess more accurate tool, I think it's fine to go into the invasive physiology. So currently, people are divided into the invasive group and image-based physiology group. But in the future, I think the basic base will be the image-based physiology, and then we may have a selected patient for the invasive physiology.
Okay, thank you. And also, we know that Dr. Song and Dr. Yang also comes from the really CAS lab. So do you have any answer for this question?
Thank you. For how to choose imaging-based or wire-based physiology. In our center experience, we used about 80% of our everyday. For the lesion selection, we used the imaging-based. I think it's saved most of our time. You know, for hospital is a very large center, work very busy, so this time and the efficiency, efficiency, I think is very important for the large center. I think the imaging base have much more superficial benefit favor than the wire-based FFR, I think. And I agree with the Professor Ku, and in some situation, I think the wire-based physiologies cannot be replaced totally by the imaging-based. In some gray zone, also in some imaging quality not good enough, I think FFR-based is very important. Yeah.
Thank you, Dr. Song. And Dr. Yang, please.
Yep, thank you. When we are talking about the ratio of the use of the physiology tool and the imaging ones, I think in my center, we basically use like 20% or something of this kind of additional tools. But yeah, to be honest, most of them are the imaging technique. Most of them are IVUS, because we are doing some, now the daily practice, we do more and more complex designs. In most CTO case, we use IVUS. Yeah. And some other things, we use IVUS, and also we use the physiology tools, especially for the region for the borderline designs, but nowadays we use less FFR than before. I think it's a kind of 3% or something, because nowadays we have some easier tool like the QFR and quite how to say, operation friendly. I mean, easy to use, save our time and our energy. Yeah, and that's our situation. Thank you.
Okay, thank you, Dr. Yang. And I see there are one question about the MUFR, so maybe after Professor Tu's lecture, so we can also ask this question to Professor Tu. Okay, so let's move on to the second topic. Let's
ask the last question. Ask the last question to Professor Ku, and then we can move to the second one.
Yeah. Okay.
Thanks, Professor Ku, for the very comprehensive presentation. So you have been the pioneer in the also in the computational physiology. I still remember you published the first FRCT paper already more than a decade ago. So many years passed. Then do you see an increase of adoption of FRCT in Korea or in Asian country? And what are the reasons behind this? Can you explain a bit about your observation?
Yes, so unlike the Western countries, its adoption is not as high as anticipated. And I think there are several reasons for that. One is the CT interpretation. I don't know the situation in China, but in Korea, CT interpretation is mainly done by the radiologist, and they are more interested in the lumen and plaque rather than physiology. And that's first thing. And second thing is that the cost issue. So heart flow FFR CT costs more than $1,000, so we cannot afford to that because our CT cost is around $200. So there are so many reasons, but one very good thing is you may know better than I do that because you're also developing and the CT-derived FFR thing. But once you have a CT scan, we have a complete three-dimensional information on lumen, plaque, quantity, quality, and very detailed hemodynamics. And I think that's the strength of the CT-based physiologic and CT all-in-one assessment. And you know that clearly Elucid, Siemens Healthineers, they all push their system to provide the integrated information on those lumen, plaque, and hemodynamic information. And with that, I think we may provide a very nice, solid information, and that will be the future. But the adoption rate have several political and business elements that prevents from more at a more frequent adoption in near future.
Thanks for the explanation.
Okay,
Okay,
thank you,
move on.
Dr. Ku. So I think we can move on to the second topics. So let's welcome Professor Shenxian Tu from Shanghai Jiao Tong University to share the speech with the meaning of the methodology and the validation of angio-based computational MUFR and other labs from a single angiographic view. Professor Tu, please.
Thank you, Peng Chen. Can you see my slide?
Yeah.
Let me. So today I would like to use the time to explain about the methodology and some validation we have been working on in the competition of MUFR and radio wall strand from a single angiographic view. So this is my disclosure. So I start with the how do we calculate the FFR? As you all know that the FR is defined by the maximum perfuse flow divided by when the stenosis is absent. So assuming that there's no stenosis, how much the flow will be. And under the maximum hyperemic conditions, this could be simplified as the pressure ratio. So distal pressure divided by proximal pressure. So if we want to calculate them, we need to calculate basically the pressure difference, pressure ratio, that since there's a pressure drop between aortic pressure and distal pressure. So essentially the most important part is to calculate the pressure drop across the stenosis under the maximum hyperemic conditions. So once you know the geometry, you know the maximum perfuse flow, and then you can calculate the pressure drop. And this has been explained in two of our review papers. So by using the imaging, you can create a geometry, and then you need to specify the boundary hemodynamic boundary condition, and you have to estimate maximum hyperemic flow. So either you are using the CFD, which you need to do complex meshing, and then simulation, or you can use a simplified flow dynamic equation to obtain the pressure drop and FR quickly. And this is what we took in the end. And here we have the CT and angio and IOS OCT. All imaging can be used for calculate FR. So this has been explained in the slide by Professor Ku as well. So basically we need to create the geometry from the imaging and the estimate hyperemic flow, and then using the flow dynamic equation to calculate them. So this starts with the QFR from our side. So first we do 3D reconstruction of geometry from two views, and then we this is how we estimate the maximum hyperemic flow. So based on contrast flow, then we calculate the contrast flow velocity, and then under the table that the computer will convert it to hyperemic flow velocity, and then we calculate the pressure drop at every subsegment, and then integrate them together to get the delta pressure drop and the delta QFR. And this technology has been validated in several and many validation studies, including the favor series study. So now we are we have organized 5 studies. 3 of them have been published and 2 are ongoing. So we expect to have the favor 4 study presented next year. So I'm going to go a bit about the validation study of the study. So the first study was called the favor pilot study. So the reason to perform this study is because we have different flow models to calculate FFR. The first one we call fixed flow velocity, a QFR, meaning that every patient will get a fixed hyperemic flow velocity. So the flow rate is different and because the volumetric flow is depending on the size, but the flow velocity, hyperlimit flow velocity is the same. So we call it fixed flow velocity, QFR. And the second one is contrast flow QFR, meaning that you are using thin film counting to get the contrast flow velocity, and still under the table, you will convert the contrast flow into hyperlimit flow and then calculate the FR under hyperlimit condition. The last one is called adenosine flow QFR. I mean that you need to give adenosine to induce hyperlimit condition, and then take the angiogram under hyperlimit condition, and then use that to calculate the QFR. So we want to know which flow model performed the best. So the result was a bit surprising because we were expecting, before we performed this study, we were expecting the adenosine flow QFR would be the best. But in the end, we found out that the contrast flow QFR is as good as the adenosine flow QFR. So both are better than the fixed flow velocity based QFR, and all three are significantly better than the dynamic stenosis by QCA. So in the end, we recommend that the contrast flow QFR as the QFR by default. And after that, we performed the Favor 2 China study and also Favor 2 Europe as well. So the Favor 2 China study demonstrated using QFR on site, so inside the cath lab, operated by the medical technician, then the accuracy can be high to 92.7%. So it's higher than the target value. At the same time, we continue to improve the ease of use and also accuracy of QFR. So this is the difference between the two generations of QFR. The first generation, you only reconstruct a single vessel. That means that you cannot detect the side branch. Then the best thing you can do is to assume that linear tabling in the reference vessel, which means that the healthy vessel as if the lumen is normal. This is important in the QFR computation. You need to know exactly the lumen and as well as the reference size in order to calculate QFR. So the first generation for bifurcation lesion is limited because you underestimate the severity proximal to the bifurcation and overestimate severity distal bifurcation. So in the second generation of QFR, we detect using AI the side branch automatically, and then the size of the side branch is measured and then calculate to reconstruct the step-down reference diameter. So if you have a bigger side branch, the flow will be taking away more, and then the reference size will be dropped more. So this would be the physiology conditions. So in this case, you will have a more accurate reconstruction of the healthy lumen, then improve the accuracy of QFR. And second, as you can see that we can perform the QFR in single view, meaning that you can using a single view without the use of two view to perform the QFR computation. And using artificial intelligence, you can automatically flow frame counting. Then you have a shorter computational time. So the advantage of the second generation, now we call it as a mu-FR or mu-QFR. So when you see mu-QFR, mu-FR is the same, because outside China, we're changing the name to mu-FR. And as you can see that the second one has improved the feasibility because it's based on single view only, and second included side branch to improve the accuracy, and then also the efficiency has been improved. And in the Favor 2 China study population, using the optimal projection, then the single view QFR can have an accuracy of 93%, and the analysis time is less than 1 minute. This has been further validated with Professor Koo using the flavor study population. So we did a blind analysis, and then it seems that the single view QFR can, even in this retrospective analysis of the data set acquired before, the feasibility can be up as high as 95%. And using well-based FFR as the reference standard, the diagnostic accuracy was 90%, which demonstrated good accuracy. So this has been also shown in people before that this post-medical can provide the QFR for this four solution, and we're changing the name from QFR to mu-FR outside China. And the other question is that was the accuracy of two-view QFR compared to single view. So we performed this study in order to investigate the diagnostic performance of single view versus two view. So using these two good projections, so only two good projections can be included in this study. So we calculate the QFR based on one of them, so mu QFR1, and the second one mu QFR2. At the same time, we the most sophisticated 3D reconstruction, including all the sidebands, and then calculate the QFR using the 3D model. And the result turned out that the single view QFR is as good as the two view QFR. So there's almost no difference. And one of the reasons behind this is that theoretically you would expect that adding more view will be better. However, in practice, that to select a second view as good as the first view is difficult. Sometimes you will have a more overlap for certain compromise the accuracy. And also there's another technical detail here I want to explain here. So many of the case that the lesion is eccentric, but the lumen can be symmetric. So this is a different meaning. So eccentric lesion, of course, in IVUS you can see that many of the lesion is on one side, so eccentric lesion. However, the lumen can be symmetric. So for example, in this case, I can see this is eccentric lesion, but lumen can be symmetric. So if you take this direction, the first view, then you get this 2D projection. If you take the second view, horizontal direction, then the lumen will be in the middle, but it's going to be long. So the lumen size will not be different between these two projections. So if you perform perfect correlation between these two views and get the 3D, then you get a round lumen. So there's no problem. So the result is as accurate as 2D and 3D. However, if you don't have a perfect correlation, so imperfect correlation, though you have a small shift there, then this one will be matched to this one, and this one will match this one. Then in your 3D reconstruction, the lumen will become elliptical here and elliptical here. So adding the second view here is not necessarily improve the accuracy, because you need to make sure that you have a perfect correlation. Otherwise, you might actually induce some error there and make the result worse. So that's the reason that we observe that the single view is as good as the second two view QFR. So this would be the workflow we recommend from the AngelPlus core software. So first, the data has been transferred to the AngelPlus system, and then the software will calculate the QFR in a single view. So only when you can identify a good second view, and in this second view, if you really see that the lumen narrowing is different from the first view, then you include the second view in the 3D reconstruction and then do the 3D. Otherwise, you will stay with single view and make the decision right away. So I'm going to show a real-time recording. Some of them might not have seen it. A recording of the how fast can the software can be used to calculate. So see this one can be completely automatic. So the software select the projection automatically, the best projection, and then it delineate the main vessel and side branch, and then calculate the MUFR. And immediately you can see the MUFR is 0.72 here, and along you can see the pressure drop along the vessel. So one important message here is that although the AI is used here, but the AI is using to only to do the lumen contouring. And so you can still check whether it's not a black box. You can still check whether the lumen is good or not. If not, you still you can have option to manually correct it. Otherwise, you will believe the result. So this solution has been demonstrated in the recent EuroPCI study presentation. So we investigate the fully automatic MUFR performance in the favored to China study population, and turn out that if you don't do any user interaction, the diagnosis accuracy is about 85%, which is better than the diagnosis diagnosis. So this is the more like accuracy validation, or and what else do we have a clinical outcome data? So the favored 3 China clearly demonstrated the QFR guided PCI improved the outcome. So compared to the angiographic guidance alone, as you can see, even you exclude the procedure MI, then she still benefit in the spontaneous MI, including the revascularization. And the benefit of QFR guide lesion selection persists to 2 years, with a similar trend reduction before and after 1 year, as you can see in this paper by Dr. Song. And the recent study from Italy also shows that This is very interesting because we noticed that the post-PCI physiology have prognosis. If you have an optimal post-PCI physiology, normally have a better outcome. So this study investigate how do you get the optimal post-PCI physiology. So one side, one arm you are using angiogram, and the other arm is physiology guided. As you can see, physiology guided PCI is superior to conventional angiographic PCI in achieving the optimal post-PCI FFR. And second endpoint is that they investigate whether there's difference between the microcatheter-based FFR or the angio-based FFR, the MUFR. As you can see that the angio-based MUFR is non-inferior to microcatheter-based FFR in achieving the optimal post-PCI physiology, meaning that this could be comparable to the wear-based. So we're not discussing about accuracy anymore, more about clinical outcome. And this is another study in collaboration with Professor Buzzota in Italy, and demonstrate that the MUFR, post-PCI MUFR, also predicted 3 years target vessel failure in the further study. As you can see here, the MUFR clearly separate clearly can predict the event. And in collaboration with Professor Ku, we analyzed the flavor study population as well. So in all the in the post-PCI, QFR was performed in all the PCI in all the PCI vessel, and especially in the IVUS, the guided PCI. And we also want to investigate whether there's a link between imaging and physiology. So using the 2-year target vessel failure as a endpoint, as you can see from this figure, for the lower post-PCI MUFR, the higher event rate as you can expect it. And also the post-PCI MUFR predict 2 years target vessel failure with a hazard ratio of 2.3. As you can see, the event separated after 1 year. And very interestingly, we observed that actually the difference is more in the IVUS guided group instead of in the FR guided group, as you can see here. So in the FR guided group, maybe the physiology has been optimal. So the post-PCI physiology does not predict target vessel failure. But in the IVUS guided group, the physiology has not been optimized, and clearly post-PCI physiology can be used to predict target vessel failure. This highlights the importance of combining imaging and physiology for the management intermediate region. So this will be the my presentation on the computational FR. And the second part is about the plaque vulnerability, as we can see from the combined OCT FR trail that even FR is normal, then if you have a high risky plaque vulnerable feature defined by OCT TAPA, as you can see, the event rate was even higher if you have a vulnerable plaque compared to the vessel without the vulnerable plaque in diabetic patient. It means that so if an analysis of plaque vulnerability on top of the current physiology can still provide additional benefit. But if every patient need to do an OCT, it's a bit costly and also introduce more invasive procedure. But the concept of our angiographic derived radial wall strength can be explained by this. So if you have a vulnerable plaque here, so during the cardiac cycle, there was more the pressure difference in systolic pressure and diastolic pressure will interact with the plaque composition with the plaque. And if they have a more vulnerable plaque, so larger lipid core and also thin cap, then you have more deformation in lumen. And this is actually hidden in the information of the dynamic angiogram. If you use the AI, can be very accurately detect these subtle changes, so that you can quantify the change of lumen diameter over cardiac cycle, match them perfectly, and you can calculate the radial wall strength. And this has been implemented in the AngioPlus core software by Postmedical. So after single view MUQFR, so if you have good image quality, you can get the co-logistic radial wall strength map. So the red color here indicates that the lesion behind this has higher vulnerability. So this can be performed within the same procedure. So this I'm going to use this case to explain to use it together for clinical decision making. This is a case that, as you can see, there's a intermediate stenosis in proximal right coronary artery. The physiology is normal, it's 0.90, quite high. However, here you can see the very hot spot here indicate that the plaque behind this is highly vulnerable. And so this vessel is actually have event 9 months later. As you can see, at the position where we have a hot spot, there's a plaque rupture here. So this technology has been validated in several studies. The first study has been published in Eurointervention. So we perform the angio-based radiation at the same time. We perform OCT, and then using the OCT to define the vulnerable plaque by this lipid to cap ratio. And then the angio-based MUFA can predict the OCT-derived vulnerable plaque with the AOC of 0.86. This is a second study, also in collaboration with Professor Ku, published in JACC Intervention this year. As you can see that the database also predict that the CTA derived high risky plaque characteristic by this vulnerability index, like positive remodeling, phosphotic calcium, napkin ring. As you can see, the higher radial strength, the more vulnerable feature that you will have. And additionally, we analyzed the additional predictive value by database. So even when the patient have a CT or this CT plaque information, and also with FFR, adding the radial wall strength on top of it can still increase the capability to predict target vessel failure. So this could be an additional value. This is another study also published 2 years ago by Fuwei, that as you can see that the in 808 intermediate lesion, so we analyze the baseline angiogram and then use them to predict whether any parameter can predict the lesion progression within 2 years. And the radial wall strength turned out to be the strongest predictor with a just hazard rate of 7.12. And another study published in JACC Intervention last year, together with Professor Junbo from Zhongshan Hospital, we found out that when the patient has a higher radial strength, the percentage of the patient lesion cause the subsequent acute myocardial infarction is much higher compared to the control group, as you can see from here. Well, analyzing the Favor 3 China study population, we found out that for those flow preserved vessel, so when the MUFA is 0.80, so if you have a radial wall strength lower, so that means that you have a more stable plaque. The event rate is also lower. So this graph will show you that you can use the technology to more safely defer the lesion. So when you have a diamond stenosis, defer it by visual eyeballing, then the event rate is 11.5. If you measure MUFA, if the MUFA is normal, flow is normal, and you defer the lesion, event rate at 1 year is 5.6. If you found out that the radial wall strength is low, so it's a more stable lesion, then event rate is 2.9. And this has been further verified in the recent target AC study population from European population. So this is the ongoing analysis. We found that indeed the radial wall strength can really nicely predict the target vessel failure, non-covered vessel failure within 5 years. So, ladies and gentlemen, in conclusion, angiographic QFR or MUFA is a feasible substitute for pressure well-based FFR measurement, and the use it to guide the PCI has been associated with improved clinical outcome compared with the angiographic guidance. The diagnostic accuracy of single angiographic view-based MUFA is non-inferior to 3D MUFA. And angiographic radial wall strength from a single angiographic projection is a novel indicator of plaque vulnerability, and higher radial wall strength is associated with coronary lesion at increased risk of the future event. And thank you again for your attention.
Okay, thank you, Professor Tu, to share this very interesting methodology and also even the history and the validation of MUFA and NWS. And we know that the MUFA is angio-based FFR and easy of use, and also now we have the NWS, which can provide more information for the clinical for the decision making. And also we see that there one question for Professor Ku. So here is a question from Christine. So Dr. Koo, good evening. And we just did a MUFR analysis on a patient earlier this morning. It's a rare case, I think. So the RCA had a moderate lesion with 60% stenosis at the proximal segment. And we did a MUFR which show an index of 0.72 at distal RCA. But the MUFR index immediately after the lesion is 0.83. So if this is the case, should we still fix the lesion even the MUFR after the lesion is 0.83, but the distal is 0.72?
Yeah, so that I provide quite a long answer to that question in the chat. So if you're interested, please read that. So this is a very interesting case example, which you can encounter every day during the daily practice. And the beauty of this image-based physiology is that when you measure it, you can have a full physiologic distribution or the complete pullback curve. So I guess that if you delta mu for across the lesion is 0.17. So I think that it's fine to fix that patients because that the very conservative cutoff for delta FFR or delta mu for across the lesion is 0.1 and aggressive cutoff is 0.15. So this patient 0.17. So I think it's fine to fix it.
Thank you, Dr. Koo. And I think we still have one question left in the previously. So I think it's about MUFR. Maybe Professor Tu, you can answer this question. So what are the pitfalls and the limitation of MUFR?
So thanks for the question. I think as any imaging-based FFR, it is important to have good quality of the imaging. So even single view MUFR, the demanding of the angiogram is less compared to two view, but you still need to have one good view. So in some cases, if you cannot get a good view, then like expose the lesion clearly, then this still can influence the result. So I think for the operator, when you use it online, make sure that you make a good angiogram. I think this is the most important step.
Okay, and another question for Professor Tu. So what kind of image quality is qualified for RWS and 2D MUFR?
So I think for MUFR, the requirement quality is not, I think it's okay, because as you can see that even in retrospective study, the feasibility of single view QFR can be as high as 95%. So most of case can be analyzed. But for RWS, it's more demanding on the image quality because we need to have the cardiac contrast filling for the entire cardiac cycle after filling the distal position. So that means that you will need to be able to see the lumen clearly within the entire cardiac cycle. If you cannot do that, then it's going to be difficult. For example, in some cases, you have a lower frame rate. Nowadays, some hospitals, they are using 7.5 frame rate. We don't recommend you to radial wall strength. So it's better to keep 15 frame per second. And then when you inject the contrast, make sure that the tester is more co-centralized, so more parallel to the center line. And then to give a little bit more contrast would be better, I think.
Yeah, thank you, Professor Tu. And I think there are two questions. Maybe we can combine them together. It's about the 2D and the 3D MUFR. So first, how can we make sure the 2D MUFR is accurate enough? And what's the advantage of 2D than 3D? And more, if there is a discrepancy between 2D and 3D results, so which one should I follow?
So very good question. So initially, when we have developed 2D, we saw that 3D would still be better, but in our practice, it's not always the case. As I explained before, that you assume that 2 view will be better because you are assuming that the second view is as good as the first view. But many of cases, you can get a good projection. In the second projection, it will be suboptimal. So this will be compromise the value of adding the second view. So nowadays, in our workflow, we recommend that only when you really see a different narrowing in the second view. So it's like a symmetric lesion, clearly in two views. For example, one view, optimal view, you see is 30% diameter, and the other one is 50 or 70. There's a difference there in diameter stenosis. You will consider adding the second view in the analysis. So this would be my recommendation. Otherwise, most of the case we will go for single view. But if you want to use it for vertical standing, let's say if you want to plan your PCI and make sure that you want to select the lens as accurate as possible, and in that case, I still recommend you add a second view there. So once you decide to stand it, you add a second view to a 3D reconstruction and get the precise stand length and diameter would be still benefit to have the second view.
Okay, thank you, Professor Tu. And I think next question is about the RWS application question. So can we use RWS in the carotid vessel restenosis lesion or even after the DCB dilation?
Good question. We have not done that. Indeed, this is the new field that needs further validation. In theory, you can use the radial strength to quantify them. Back for restenosis, probably yes. But if you just immediately after standing, the stent, the lumen contour will be less clear. So maybe that's the limitation. But for carotid lesion, that could be a very interesting field to work with. We have not done that yet.
Okay, thank you. And another question. So, is it possible to use RWS to replace OCT?
Very difficult question. We have been questioning about this in our review paper. I think that the radiation is not going to replace OCT. It's more like you are not expecting to perform OCT in every lesion. So I think it can be the first step. If you perform radial wall strength, and then you see if radial strength is normal. Most of the cases is okay because as I mentioned in the target AC study recently we analyzed them. Even after 5 years, if you have a very low radial wall strength, very few vessels will have event in 5 years. So I think if you have a normal RWS, you just can defer it without doing further imaging. But if you have a high radial wall strength and if you want to make a decision, maybe sometimes adding the OCT there can add additional information. But of course, you need to consider the cost effective as well. So if there's no issue of cost using an invasive OCT, I think if you measure radial wall strength, if it's high, then adding an OCT there can be a possibility. But if it's low, I would recommend that just defer it without doing further imaging analysis.
Okay, thank you, Professor Tu. And so still a lot of questions. Maybe we can select one to answer, and for the rest of the question we can type in the chat box. So maybe it's about it's a question from Siripong. I think it's a doctor from Philippines. So could we use MUFR in severely tortuous coronary arteries?
Good question. I think that if you can get a lumen contour clearly delineated, you can use that. If you cannot get the lumen contour clearly delineated, that's the problem. Yeah. So the accuracy of the MUFR is depending on the accuracy of your lumen contouring.
Okay, thank you, Professor Tu. And still some questions, so maybe we can left it in the last discussion part. So for the third topic, let's welcome Professor Song Lei from Fuai Hospital to give us a speech about the application of evidence-based MUFR in the whole process of coronary intervention. Professor Song, please.
Thank you. Thank you for the invitation. And this evening, I'm glad to share my experience of application of evidence-based MUFR in the whole process of coronary intervention for a hospital. as we all know, recently published the ESC management guidelines for chronic coronary syndrome. They recommended that using FFR or IFR based lead-in selection strategy to determine how to perform the resuscitation in intermediate stenosis. The recommendation is 1A, and it's the first time to use the functional assessment get this recommendation. And we all notice that QFR, the first time, was recommended from the guidelines of the from the ESA. We also get a recommendation of 1B, that's with a cutoff of less or equal to 0.8, very similar with the FFR and IFR. And all this recommendation is based on the evidence from the Favor 3 China and the 2 years outcome, the Favor 3 China and Favor 2 China. And all this evidence demonstrates that the accurate of the imaging-based FFR compared with FFR reference, and in the real world, we demonstrate that imaging-based FFR can compared with the angio guided PCI can lead to a 35% MACE risk reduction. And for now, QFR-based lead-in selection strategy improves long-term clinical outcome compared with the angiography guided PCI. And we also showed that the benefit is similar among all pre-specified subgroups. And for now, we have published lots of subgroup analysis, and another more subgroup analysis is on the way, like the gender, ACS, QFR gray zone, multivessel disease, etc. And based on the Favor 3 China, we only focused on the low to intermediate risk, and most of them are stable population. And in the Favor 4 and Favor 5 AMI trial, which we randomized now, we will evaluate the mu-IFR optimized readaptation strategy in a more high-risk population with acute mild infection and multivessel disease. And let's just say that the mu-IFR and all other kinds of imaging-based FFR is now to challenge the status of the wire-based FFR, but compared with wire-based FFR, imaging-based physiology have more advantage, specifically in the time saving. We cannot now need to use the wire and now need to use the hyperemic agents. And although we all know that not only lead-in selection but also the PCI strategy and the post-PCI optimization is very crucial for using the physiology assessment. But if for a multivessel disease, we repeatedly do the wire-based physiology assessment, pre-PCI, during PCI, post-PCI, and for each epicardial vessel, it's very a waste of time and not always a safe procedure. Sometimes it do some harm to the patient, like some repeatedly using agents and wear in and wear out. And if we use imaging-based physiology, I think it's much more advantage than wire-based FFR. It's more easily for us to combine this physiology assessment in our everyday work practice and workflow. And for pre-PCI, I think using imaging-based FFR, we can also generate a score as a functional syntax score, like the FFR-based functional syntax score. And we use the post hoc analysis as the Panda 3 cohort with the functional syntax score based on mu-IFR can appropriately reclassify the patient with better discrimination risk for prognosis. And like this figure, we can show that about 5% of the patient from the high scores group to the intermediate group, and about 10% of the patient from the integrated group to the low group, low score group, and about 1% from high just down to the low score group. And we also can see that about 6% of patients can avoid unnecessary CABG surgery and can change to a group favor to PCI without increase some long-term risk. And a PPG, which we call the pull back pressure gradient measurement, also coming from the wear-based FFR. And the PPG index could quantify the physiology diffuse and discriminate the physiology patterns of the coronary artery disease with physiological focal coronary disease and the physiological diffuse disease. We can also very easily use this version of the QFR to measurements the PPG index to separate the patient from the diffuse or local pattern. And using a post-hoc analysis, we can with the physiological diffuse pattern, which means the PPG less or equal to 0.77, acquired the higher 2-year risk than those with the physiological focal patterns. And we notice that in this 3 curve, the red curve, that means that lower PPG, that means the very diffuse lesion, if we treat it with PCI, have comparable long-term result when as those with using only conservative strategy, which means that optimal medical treatment alone, which much higher the risk than those patients with the blue line. That means the high PPG with a low, very focal lesion treated with PCI. That means that for some, if we treated the patient, we should evaluate the PPG pattern before we really put a stent in the vessel. If the patient have very diffuse lesion, the PPG less or equal to 0.77, we should consider if the patient really appropriate for can benefit from PCI. Maybe this patient should treated with optimal medical therapy only, or maybe this patient should transfer to the CABG. And another very useful technique we call it the virtual standing or a simulated residual μFR, which is a prediction of the actual post-PCI μFR. And just Professor Koo just talk about this technique. I think it's very useful for the operators. We can evaluate the physiology result before we really put a stent there. We can plan our strategy without our goal of this technique is to put as minimize the length of the stent to get a maximum of the physiology result. And it also, we noticed that it was associated with a long-term progress, can be a promising approach to PCI optimization. And this slide shows a virtual standing with this one projection. QFR, we can say is mid-lesion stenosis of RCA, and with QFR is 0.74, and they have 2 lesions, mid RCA and distal RCA. And if we put stent just the proximal, the residual μFR is 0.95, and if we put stent in the distal RCA, the residual μFR is 0.87. And if we standing out these two lesions, and the residual μFR is 0.99. And obviously, if we only treat residual the proximal lesion, I think the residual μFR is good enough, and now need to put another stent in the distal, and maybe not totally not necessary. And with this technique, using the μFR guided virtual PCI standing, we have more patients can get a final physiology final physiology μFR greater or equal to 0.9 compared with the angiograph guided patient PCI. And μFR also have some applications in during PCI online measurements. And the one very interesting application, I think, is can give some recommendation for the best projection. We know that our regular projection is from the experience, and sometimes we notice that in some situation it can cause the more foreshortening than this computer generated optimal views, and it also is theory based on the 3D QCA, and it gives some optimal projection to show the lesion and avoid the foreshortening. And we know all the imaging-based physiology is based on a good imaging quality. And if has some foreshortening, it can maybe in some time to impact on the result. And if you're using the recommendation from the computer, it gives us a more opportunity to have a good quality and good result. And this is an example show that the standing selection by the 3D QCA guidance. And this is a mid LED lesion, and the vessel μFR is 0.77, and we can see that the system recommended the optimal projection is LAO 15 degree and cranial 45 degree, and at the maximum avoid the foreshortening of the vessel. And from the visual standing technique, it's recommended that the proximal diameter is 2.4 and the distal diameter is 2.2. But based on my experience, the 3D the QCA maybe undersize the diameter. So if we use this information, we usually upgrade 0.5 millimeters. If we put standing here, we usually put 2.2 millimeters plus 0.5. That means we put the 2.75 stand, and the length. The stand length is very accurate, I think, based on the QCA, and the stand length is 34 millimeters. So for this patient, if we put 275 by 33 millimeters stand in the mid LED, we can get a 0.9700 μFR. Very good, very satisfied physiology result. And in the future, I think in our CAD lab, it may be more and more imaging and physiology modality can combine together. And I think not only the coronary, but also some the physiology and intracoronary imaging, and maybe the CT, and all this imaging can give the operator more information based on the image of anatomy and physiology together. And also for the post PCI, imaging-based physiology gives some information for the very crucial data to optimize the result. The principle also comes from the wire-based FFR, like the target FFR 12. And after anatomic successful PCI, about nearly 70% of patients have initial suboptimal result. And if using a physiology-guided incremental optimization strategy, because the 30% of patients should need further intervention, with more patients achieving a final post PCI FFR greater or equal to 0.9. So this idea also can transfer to imaging-based FFR. So we do a post-hoc analysis using the PANDA3 cohort. It shows that the post-PCI μQFR can predict long-term prognosis. And the vessel with the post-PCI μFR less or equal to 0.92 was associated with a poor progress. And this result was consistent whether the patient have diabetes. And we also can use the post-PCI physiological analysis to use the PPG and to evaluate the post-PCI physiology pattern is local or diffuse. If there is exist of the local severity, and compare with the visual just only based on the angel, about half of the patients were classified by the physiology analysis post PCI. We see that we can separate the patient with 4 groups. The first group is the focal residual disease without major gradient, and the group 2 is focal residual disease with major gradient, and other group 3 and group 4. And we notice that for the 2-year outcomes of the VOCE and those patients with first group, that means that the focal residual disease without major gradient have the best long-term outcomes. And for those patients in the group 4, that means even after PCI, the patients still have the diffuse residual disease with major gradient has about 6 or 7 times of long-term risk. And we defined a principle as the mu-QFR concordant PCI. That means to treat all the physiological significant vessels by PCI should be treated. And all the vessels with mu-QFR greater than 0.8 should be deferred. And all these patients, if patients meet all these criteria, this means the mu-QFR concordant. And otherwise, we call it the QFR non-concordant. The mu-QFR non-concordant patient, including some situation like the under-treatment or over-treatment, and both of the over and under-treatment for some patient with multivessel disease. And whether before or after IPTW adjustment, mu-QFR concordant treatment was significantly associated with improved 2-year MACE. And we noticed that in this figure that the MACE of the QFR non-concordant is 8.8%, and for the concordant is 8.8%, and for those non-concordant patient is 13.6%. And we're also using post-PCI physiological evaluation using the left main bifurcation PCI group. We use 1,200 patients in Fuai Hospital perform left main PCI. We perform the post-PCI evaluation of the left main bifurcation. We define the post-PCI residual ischemia group as the post-PCI LAD or circ less or equal to 0.8, all those patients without residual ischemia, which means the post-PCI LAD and the circ mu-QFR greater than 0.8. And as a result, we notice that about 10% of the patient have residual circ ischemia, and about 2.7% patient have LAD residual ischemia, and about 0.5% patient have both LAD and circ residual ischemia. And far beyond our expansion, we expected only some difference in the outcome of the revascularization, but the real results show us that the ischemia, the residual ischemia also impact the long-term cardiovascular death, as this 2 curve show that those patients with residual ischemia, that about 3 times of the cardiovascular death compared with those patients without residual ischemia group. So same result we can show that in the BOCE, that which means the bifurcation-oriented cardiovascular disease. The rate of was 17.8% versus 5.8%. And this finally, this is an example. This is a 74% male patient with multivessel disease, LAD bifurcation with a diagonals and LSC a circ with mid circ have 80% and proximal RCA have 80% stenosis. And for the traditional anatomical syntax score, it have 24. And for some for MILC-FR based functional syntax score with circ, MILC-FR circ is 0.85. If we minus this 3 point, the final functional syntax score is 21, which can favor the PCI. And after calculating the MILC-FR based functional syntax score, PCI strategy should be performed. And so this patient is suitable for PCI. And based on the principle of the MILC-FR consistent strategy, and all the functional syntax score significant vessels were treated, and all the vessels with MILC-FR greater than 0.8 should be deferred. And so we should treat LAD and RCA, and the circ will be deferred. And all these 3 vessels was physiological focal pattern, so these all can benefit from the PCI. And for the step 3, we use the virtual standing. Our target is the optimal post-PCI functional score greater than 0.92, and which was associated with better prognosis. And we use virtual standing. We planned the 3 strategy to treat both proximal or distal, or both proximal or distal. And for this LAD, we choose the 3rd strategy that we put a stand covered all the 2 lesions to achieve the final MILC-FR of 0.98. And for the proximal RCA, we use just put a short stand could achieve the final residual MILC-FR is 0.96. And for the 3D QCA, can help us choose the optimal diameter and length of the stand. And this is the final result. For the post-PCI MILC-FR, the actual post-PCI MILC-FR is 0.98, very similar, almost the same as our residual visual standing, visual QFR. And post-MILC-FR RCA is 0.95, also very similar with visual standing. And post-standing physiology pattern shows that PPG was 0.97 and 0.89 in the LAD and RCA, and also associated with a good long-term outcomes. And as a summary, angiography-based computational physiology index has compatible diagnostic performance with VFR and FFR. And the phase 3 China have demonstrated that compared with the angiographic guidance, QFR guidance could significantly improve 1-year clinical outcome driven by fewer PCI-related adverse and better long-term outcomes. And QFR is the only, for now, is the only angiography-based FFR which has been shown to improve long-term clinical outcomes. And MILC-FR is easily safer and more conducive for the application of physiology-guided PCI in our daily workflow. And it can be used in pre-PCI lesion selection, during PCI decision making, and post-PCI optimization. And more importantly, can saving clinical results. And wear-based FFR, of course, cannot totally replaced by the imaging-based FFR, and is suitable for some cases in which computational physiology is inaccurate or inappropriate. Thank you.
Okay, thank you, Dr. Song, to share us a lot of evidence-based practical application of MILC-FR in different PCI stage for the decision making during the PCI using some virtual standing. And also we see that there are questions about the virtual standing. So can we directly using 2D recommended virtual standing lens diameter to select the stand or DCB?
Yes, for the use of DCB, we still have no much solid validation evidence, I think. And in some limited report, I think the cutoff if we use the DCB is also based on the cutoff like the 0.89 or 0.90, those which we will have a better outcomes. But for the DCB, in my experience, is limited by the clear contour opposed the balloon PTCA, just like the cutting balloon or some scoring balloon. Usually after that, some dissection of the vessel can impact the accurate of the imaging-based FFR analysis, I think.
Okay, thank you, Dr. Song. And another question still about the planning. So how effective can MIRFAR as a PCI planner in patients who undergo diagnostic angiogram?
I think the diagnostic angiogram is I think the diagnostic angiogram is absolutely imaging-based. The QFR can give more information, and if only the diagnostic angiogram can, if they combine with QFR, I think and the more we can use the, if I think it's in the gray zone, I think like intermediate lesion stenosis, I think QFR is very maybe very useful. If the diagnostics accurate the angio shows that a very tight lesion greater than 90%, I think it's not necessary to use another physiology assessment. Not only the imaging based, but also some wear based is not necessary. But for some we call it intermediate lesion, that 30 to 80%, I think is necessary.
Okay, thank you, Dr. Song. And I think another question about the really clinical application. So FFR have a lot of maybe limitation in different age group. So is this true?
I think in the different age, I think it's almost I believe it didn't change the result. I think based on our experience, also on the evidence from the previous China, we have a pre-specified age subgroup. The analysis shows that the accurate and the outcome based on the QFR leading selection is all the same among all the different age group. I think actually similar in the FFR.
Okay, thank you, Dr. Song. And another question from Ricardo Pablo. So, for example, if the residual MIRFAR will generate a value of 0.89 with a single stent, and if you do a two-stent analysis, it will yield 0.99. So, will you use the single stent be enough, or much better to have the two stent?
Yeah, it's a very good question. How we choose the stand? Is we put a longer standing to achieve a much higher physiology result, or if a shorter standing maybe give us some acceptable result. But I think it depends on how distal should we treat to get this result. If we just put a standing that as the mid segment of the vessel, not very distal, we now need to put very small stent with I think is acceptable, and we could put two standings. Even three stand is also okay. It gives some opportunity to the future, maybe the future cabbage. And I think if we have to put a more standing, more distal, very small size of the stand, I think it's not necessary, totally not necessary. And also we can use the measurements that like just introduced the PPG. If the patient is have a physiology pattern or very diffuse lesion, if the PVG shows that the patient will not benefit from the very long-standing, and so we have to put a very long-standing to get a better a final QFR. I think maybe this patient is not appropriate for PCI.
Okay, thank you, Dr. Song. And another question for you. So from Qing Wing Chen. So is there any validation of MUFR in left main or still using the same cutoff 0.80?
Yeah, for now we still use the same cutoff of the left main or non-left main disease, but we still now to do some special analysis for this very high risk patient. But for now, and Professor Chen Jie in Fuai Hospital have just for now underwent a study compared with the MUFR and the average derived FFR in this cohort, and maybe we can get more evidence from this study in the future.
Thank you. Yeah, thank you, Dr. Song, for sharing. And I think we can move on to the last topic. So let's welcome Dr. Junqing Yang from Guangdong Provincial People's Hospital to share us the functional IVUS guidance process PCI. Dr. Yang, please.
Yep. Thank you very much. I'm so glad to be involved in this webinar, and I carefully listened to the speakers before and after you guys address the concept, the technology, and the evidence of this kind of imaging-based physiology technique. I would like to illustrate the value of this kind of technique. Use the UFR and MUFR as examples. Okay, close the box. Yep. I think for everybody of us, everybody will agree that the first question when we face to a technology, no matter that it's for diagnosis or for treatment, we're going to ask whether this technology will improve the prognosis or not. And in terms of the intravascular imaging or physiology tool like IVUS and FFR, we're going to ask firstly, is it good? Actually, there are accumulated evidence to show that no matter FFR or IVUS, do good for the prognosis when we use this kind of techniques on the top of X-ray based angiography compared with the pure X-ray based angiography. This kind of meta-analysis also show that. And which one is better?
Sorry, Dr. Yang, I think the presentation is still in the first page.
Is it mobile?
Still in the still in the first page.
Okay, let me stop and share again.
Yeah, thank you.
Yeah. Can you see my title page?
Yeah,
and the
title page. Yeah, it's moving.
Okay, it's moving.
Okay, thank you.
Sorry for it. Yeah. As we mentioned, there are already accumulated evidence to show the benefit of the imaging as well as the physiology technique for the prognosis. And the next question is, which one is better? Is the imaging or the physiology technique? the recent flavor trial perfectly answer these questions. They're similar. For prognosis, they're similar. And as all of us already know before, the physiology technique always cut down the procedure number. Okay. On this background, the next question where easy to go is, if we put the imaging and the physiology technique together, I mean combine them, will it be better than we just use it singly? Okay. There are no direct evidence, but fortunately, when we compare the syntax serial trial, we can see for the syntax 2, which we combine the imaging and the physiology tool together, we get a better result compared with the syntax 1, the PCI arm, which we just use 1, 2. Yeah, no matter the primary composite endpoint or the all-cause test, seems when we combine the FFI and IVUS together, we get a better results. Yes. So we are going to consider. Actually, at this time, we go back to the history. In the during the past, guys want to use imaging technique, which show the anatomic information to take place the role of the physiology technique like FFR, but the result is to some, I would like to say, somewhat it's okay, but it's not far from perfect. It's hard for the anatomic tool to take place the physiology results. Okay. When we look at the literature, we can see even for the IVUS, we get a very different cutoff. If we pick up the minimal lumen area as a cutoff to predict the FFR results, very too much. And even for the dead man, which the variation is less compared to the other artery segments, we cannot get a very focused one cutoff. We get the we recommend that if the minimal lumen area is more than 6 millimeters square, we have a high chance, high opportunity to get the negative FFR, but it's not 100%. But when the lumen area is at the borderline like 4.5 to 6.0, it's very hard to tell how is the functional or the physiological significance. So at this situation, I think it's good to use a FFR. But in our everyday practice, everybody of us know that there is some cost for us to use two kinds of technique in one procedure. Not only the cost, not only the money expense, but also the time cost. Okay, so the next question is, do we have anything like one stone or two birds? That means just one technology, one technique can show us both information of the anatomy and the hemodynamics. Yes, there is something we call the imaging-based computed fluid dynamics index. Guys would like to call these index FFR, computed FFR, but actually it's a little bit, there is something different between the so-called CFD, I mean computed fluid dynamic index compared with the FFR. Good thing is nowadays we have a bunch of this kind of thing like a QFR based on the angiography, or the QFR based on CT angiogram, which the second generation technique was called mu-FFR. Mu-FR, yeah. And the ones based on IVUS and OCT was called UFR and OFR, respectively. This kind of technique is the perfect one stone we can use for two birds. Cause the imaging itself have the information of the anatomy, and with the computation, we get the information of the physiology. Yeah, no matter the QFR, the mu-FR, or the UFR. Like, let's look at this interface. We're easy to get the cross-section imaging, as well as the longitudinal imaging, not only the main branch, but also the side branches. Yeah, we have the information of the anatomy as well as the physiology. This is the UFR. We get the vessel UFR. That means via the whole pullback, we calculate the UFR as 0.82. But another thing very important for me myself is we can easily to get the gradient. We just move our mouse from here to there. We can know the drop between this segment, the so-called mu-FR gradient or something. Yes. And compare with the pure imaging technique, this kind of UFR is quite better than it to predict the function, the physiology results. After this, next I'm going to use two cases to illustrate the value in our everyday practice. The first case is an old gentleman who suffered chest tightness for 1 month, and with the angiography, we can see the right coronary is acceptable. Just there was something tight at the mid-LAD. Seems it's not very severe, but the symptom is quite typical. Yeah, also the circumference is good. So we check the mu-FR for the LAD. We can get that the vessel mu-FR is 0.72. It's kind of over 4.0. There is something drop over here. Yeah, it's quite focal. It's here. But the whole vessel, it seems, is not significant dynamics. And when we check the IVUS and calculate the UFR, is 0.85. It's nothing surprising that the UFR number value is a little bit higher than the mu-FR. Why? Because with the mu-FR, we can draw the whole vessel, very long, but okay, with the UFR, we just calculate the segment where we pull back the IVUS. This is always something shorter than the angiography. So usually there is a little bit higher of the calculated number, but that's not a big deal. when they are all negative. And okay, to be confident, we check the FFR, and the FFR is 0.83. It's very close. That means no matter our mu-FR or UFR, it's quite accurate. So yeah, we can, based on this result, since we can defer this patient, but why the patient suffered some symptoms? The answer is here. When we pull back the wire, we found that the vasospasm over here. And this time, when we check the mu-FR, it's quite lower than before. This is perfect. This perfectly explains the symptom, why the patient suffered the symptoms. Yep, this is the first case, the negative case. And the second one is the positive case. It's also a gentleman. And the gentleman suffered from multiple vessel disease. It's the LAD, the circumflex. The white now is in the diagonal. Okay, don't worry about it. But when we check the IVUS, see, since the plaque burden is quite high, the lumen is small, no matter for the LAD or for the circumflex. But another information is at the after the mid segment, I mean at the mid distal segment of the LAD, we get some muscle bridge. Okay, myocardial bridge over there. This is the value of the imaging technique. Okay, nothing surprising when we check the mu-FR or the UFR. Okay, we didn't check the UFR before. We don't need to check it. Both ratio is positive. Okay, if I blend it, cause the mid-distal segment, there is some muscle bridge there, myocardial bridge. I mean, we just stand the proximal to mid-LAD and the circumflex. And after that, we get the post-standing mu-FR is both of them, both of the mu-FR of the LAD and the circumflex over 0.90. When we get this number, we can go back to check the pre mu-FR. See, the pre is the 0.73, but another important information over here, that's a 0.91. That means what? Means the residual mu-FR. That means when we fix out the proximal visa over here, we can get it over 90 over here. And for the circumflex, it's also 90 something. And compare with the final result, it's similar. Important. And I mean, with the residual mu-FR, it also helps us to do a plan before the PCI, which was shown by Dr. Song. Yeah. Okay. So finally, I'd like to summarize that no matter FFR or mu-FR or UFR, both physiology and computed physiology technique, as well as the anatomic technique like the imaging, like the IVUS, both of them, all of them, help us to improve the prognosis. And IVUS and FFR is similar for the prognosis, but when we combine them, it may be expensive and maybe something cost. And there are nowadays some computed technology like MUFR and QFR and UFR. We can use it for the everyday practice. We use this one stone for 2 birds to improve our procedure result as well as the patient's prognosis. And that's it. Thank you.
Okay, thank you, Dr. Yang, to share us a lot of intravascular imaging and also some IVUS-based physiology technology. And we know that you have a lot of experience in the IVUS and also the physiology. So I think maybe you can also share your comments to the question in the chat box. So the first question is about is from Sirupong. So how much does it cost the cancer reimbursement? So maybe I think it can maybe you can share some situation in China.
Okay. In China, in our center, it's around 2 kilo or something RMB for the QFR. That's it. And for the MUFR, so far we don't charge to the patient yet.
Okay, thank you, Dr. Yang. And another question, is it possible to use only IVUS to guide the PCI, or the so-called zero contrast PCI?
Okay, this is sounds fantastic technique. In some extreme case, I did this for the patient. Basically, for the patient with very severe hypergenic, 过敏怎么讲？hypersensitive patient, which quite hypersensitive to the contrast, but there are impossible to use a zero contrast for the patient. No matter you use it for the invasive coronary angiography or you use it for the CT angiography before this procedure. For the few cases, I use this kind of zero contrast PCI technique. Of course, with IVUS, that's because the patient suffer quite severe allergy, and it's hard to put the patient second once again on the contrast. And we based on the previous angiography information and use IVUS to guide this time procedure. It's possible for the single procedure, but impossible to use no contrast all the way. I mean the absolutely contrast.
Okay, thank you, Dr. Yang. And another question for you. So is it possible that UFR give a discordant result, negative ischemia, but MLA is very small?
Yes, of course. In some case, if the vessel, the sick segment is quite distal and perfused myocardium is small, it's possible to get the negative results with quite small lumen area. That's it.
Thank you very much. And I think that we already reached 9 p.m. in China, and maybe it's already 10 p.m. in Korea. So thank you everyone to join today's. Also, sorry, I think another question. If there is discrimination between IVUS and MUFR, so how can I make the decision? So this question is about the difference between physiology and intravascular image.
Okay. No matter MUFR and UFR, it represents the physiology. So when I'm concerned about the physiology, I use the information of MUFR or UFR. When I'm consider about the anatomy, I use the information from IVUS. Usually, based on the traditional concept for negative hemodynamic negative lesion, we defer it. So in this time, we make a decision based on the MUFR or UFR. But if we consider about the vulnerability of the plaque, like which we discussed with Dr. Koo, we may take the anatomy. We may take the imaging information into account, no matter IVUS or OCT. Of course, we also can use the computed, the imaging computed hemodynamic index like RWS, which mentioned by Dr. Tu, by Professor Tu earlier tonight.
Okay, thank you, Dr. Yang, to share your opinion. And so I still want to thank everyone to attend this meeting. And actually, we found that almost during the whole meeting, about 90 or 80 attendants stay in the webinar, and also a lot of questions. And first, thank you very much for all the speakers to share your presentation, and also thanks for the attendance about your question and the discussion. So I think it's very glad to have today's webinar, and also we should have a good night. Okay.
Thank you.
Thank you very much.
Thank you.
Bye-bye.
Okay,
Thank you.
bye-bye.
Thank you.